channel. My name is Dr. Wisdom, and today we are continuing from where we stopped on our last series on demystifying glaucoma, the past, present, and the future. So, in our last class, we were able to identify and define the concept of glaucoma, the causes, and then the basic things you ought to know about glaucoma. So, if you are just joining us for the first time, please do well to watch the part 1 and part 2 and make sure that you are followed up. And today is the part 3 of demystifying glaucoma. So with no further ado, I want to begin to teach on what are the signs you look out for during glaucoma screening or glaucoma examination. So most times when the patient gets to see the doctor, he's intrigued and he wants to know what actually is the doctor seeing that I'm not seeing. So in the optometric practice, there are what we call the subjective tests and the objective tests. So the subjective tests are dependent on the patient. In other words, the patient's response is needed in order to fine-tune and know the next step to take. But there are some tests that are objective in the sense that you do not necessarily need the patient's response. All you need is the patient's cooperation, and then the doctor can be able to identify or isolate 1, 2, or 3 cases as the case may be. So in glaucoma screening, most and every time, it is an objective test in the sense that the patient just has to cooperate, and then the doctor begins to run the test of ophthalmoscopy. So my emphasis this evening is on ophthalmoscopy or your fundus camera imaging. So what are the landmarks or the features the doctor is supposed to look out for and be able to explain to the patient? So there are many of them, but I will just be listing out a few and then hoping that you will go on and make more research on them in order to build up your clinical dexterity. So the first thing we'll be looking at is the neuroretinal rim. So upon ophthalmoscopy, ophthalmoscopy is a test geared at examining the interior part of the eyes. So when we can look at the lens, we look at the vitreous, we look at the blood vessels, we look at the disc, we look at the fundus generally, and then finally we look at the macula. So during a glaucoma screening, you want to examine the neuroretinal rim. The neuroretinal rim is the space between the edge of the disc and the edge of the cup. So that is the inner edge of the disc and the outer edge of the cup. So we want to examine it and know how it is. Normally the color is usually healthy and pinkish yellow in color, but when there is a loss of nasal neuroretinal rim, it could be indicative of glaucoma. A loss in the nasal neuroretinal rim, it is indicative of glaucoma, and this should raise suspicions to the doctor for further tests. So remember the Ising rule. That is the inferior, superior, nasal, and then temporal. So this is a guide for you to be able to isolate glaucoma effectively. Again, we want to look at the cup to disc ratio. So there is what we call the cup to disc ratio. It is a ratio of the size of the cup to the disc. So for most times, some people can overgrade or overestimate or underestimate the cup to disc ratio. So for instance, when the cup is too large, when the disc is too large, you are likely going to be overestimating that the cupping is large, because if the disc is large, probably the cup will also be large, and if the disc is small, probably the cupping will be small too. So in the case of a large disc, it is important that we do not just overestimate because the disc is large and then we assume that it's a large cupping. Are we together? So the cup to disc ratio is very, very important in diagnosing of glaucoma, and the normal range is 0.1 to 0.4. So when we begin to see from 0.5, 6, 7, 8, 0.9 is suspicious of glaucoma, and yet one can have a large disc and yet it is not glaucoma. So we call it physiological cupping. But before physiological cupping can be established, all other factors must have been ruled out, and then we are sure that this is a case of physiological cupping. And even if it is a case of physiological cupping, we still want to examine them from time to time in order to be sure that it is not progressing. So this is why it's good you have a record of every time you come to the clinic. We want to know what the cupping was 2 years ago. For instance, if the cupping 2 years ago is 0.4 and then in 4 years time it is 0.6, we know there's a progression. And remember, glaucoma is a progressive enlargement of the cup. Glaucoma is never fast, so every time we see a fast increase in the cupping, maybe last month it was 0.5 and this month it is 0.78, as long as the last cupping was correct, we are sure that it was the doctor who noted it didn't do a mistake or didn't underestimate or overestimate. If we are sure that the cupping is correct, then likely we are not dealing with glaucoma, because glaucoma is usually a slow progressive degeneration. It is not usually fast in its progression. So when we see a quick a fast progressive degeneration, likely it is not glaucoma. And again, when there is a band of a loss in the neuroretinal that is horizontal, it also gives rise to certain questions we must ask. So the cup to disc ratio is very, very important, and then we must note it effectively. Also, the cup to disc size is also important, that it is necessary that it is noted, so that we will not be overestimating a cup meanwhile the disc is large, or we will not be underestimating a cup meanwhile the disc is small. So another thing we want to look out for during ophthalmoscopy is barring. There's what we call the barring of the blood vessels, whereby you see the blood vessel as if it is giving you a U shape, as if it is being stretched and then it is hanging on something. So barring is another important feature to note in glaucoma. Also, another important feature we ought to note is what we call the bionetting. So there's what we call the bionetting of blood vessels, whereby the blood vessels, they enter into the discs and then it's as though they disappear, and then you see them come out again on the other side of the disc. So this is a sign of glaucoma when you see bionetting, barring of the blood vessels. Also, the peripapillary atrophy is like a pale black patch around the disc. It's also some scholars have opinion that is also a classical sign of glaucoma. So it is important we know this. Also, the retinal nerve fiber layer, it is important that it is also highlighted, and you can visualize the retinal nerve fiber layer effectively during or after an OCT test, whereby you can see how the nerve fibers they collapse into the disc. So it's important that these things are noted. So these are just the basic things we want to look out for during the optic nerve head examination. So if you can look out for these things, it gives you a guide in diagnosing glaucoma. So also, now that we have been able to diagnose a patient of glaucoma, what do we do next? There are some further tests we want to send them for. The first, like I said in the last video, we want to send them for pachymetry test. We want to know the thickness of the cornea. Also, OCT, optical coherence tomography, is an important test that should and must be sent when a patient has glaucoma. Also, we want to look at the anterior chamber depth to know how deep, if the chamber is shallow or deep. Also, the CVF test is also important. It helps us to know it helps us to get a good picture of the visual field, because if glaucoma affects peripheral vision, and if there is a loss in peripheral vision, it gives us a guide on the extent of the degeneration of the glaucoma. So this is important that we note and send for this test. So remember, you are sending for tonometry, for pachymetry, OCT, anterior chamber depth, and then the central visual field. So these are the important tests to do. In our next class, I'll begin to be talking on the treatment of glaucoma, and then I'll be talking on the first line treatment, which is selective laser trabeculoplasty. So this is it's not probably a new technique anyway, but in some parts of Africa and maybe in Nigeria, it is a new technique, but it has always been there. So in my next in the next class, which will be next week Sunday by 5 p.m. again, I'll be throwing more light on what SLT is all about and what it entails. So thank you for joining us today. This is just a brief class. Next week we'll take it again, and then we'll make sure that everyone follows and understands what I'm trying to teach. Don't forget to subscribe, like, comment, and share the page. God bless you. I hope to see you next week for another refreshing time with Dr. Wisdom.